Welcome to Health Talk. Today we're going to talk about blindness and how people feel about it. Are they afraid? And what is happening with blindness in America? With me today is Dr. Vikas Yalapu and Mary Gao. So I'll start off being the ophthalmologist. Blindness, there are three leading causes of blindness in America. Number one, glaucoma, affecting all ages. Number two, diabetic retinopathy, affecting people from age 21 to 65. And age-related macular degeneration, which occurs after age 55. So tell us, what are your questions? If you have patients, what do you think?
So I've come across a lot of patients who have diabetes, and one of the first symptoms they tend to have is problems with their vision. Is this your experience? What would you recommend to these patients with diabetes?
As an ophthalmologist and retina specialist, I've dealt with diabetic patients all my life, all my professional life, and diabetes now affecting 29 million Americans in the last census. It has been estimated to be 26 to 29 million, and it is rising. We feel that there is there's a third more, 8 million not diagnosed. So what happens is, if they're not diagnosed and they're finally diagnosed with type 2 diabetes, which is the adult onset type, they probably had it a few years before. So by the time they go to the doctor and are diagnosed, they have changes in their eye. So what happens with diabetes and the eye is that here's the eye, and here's the front of the eye, the cornea. This is where people put their contact lens on. Next, you have your iris, if you have blue-colored eyes or brown eyes. And here's their lens. This is where the cataract occurs. And here, inside the eye, is the retina, the inside lining of the eye, like the film of the camera. And this retina is where diabetics have changes in their vision. So it's called diabetic retinopathy. Retina for this area, pathy for disease. So what happens is that diabetes affects the smallest blood vessels first, and the smallest blood vessels are in your fingers, tips, and your toes, and also in your eyes. So we have blood vessels here as small as 25 microns and even smaller. So they will show changes. So changes there will magnify big in the patient's view of life. So they will view things first if they're newly diagnosed with diabetes, such as reading the San Jose Mercury News. They'll be missing letters such as the A in apple, or if they're looking out their window or looking at their mail, there'll be a constant smudge in the center of their vision. And if that is happening, to see an ophthalmologist, an IMD, we go to medical school, or an optometrist. They do not go to medical school, but they do get 4 years of specialized training in optometry school. At least they can tell that glasses will not help them. And then they need to see somebody like us, a specialist. So it's very common for me to see people who are newly diagnosed, yet they already have significant eye disease. So they already cannot see the center. They're missing their grandson's face or the nose on the face. So they're missing their wife's ear, or they're missing part of their wife's eye, or their husband's part of the face. So they're missing. So their view of their life is smudged. So that's early. And then if it's very later on, if they really had out of control diabetes and finally they went to a doctor, they may come to us with no vision at all. So instead of this nice eye looking like this and it's empty here, it's filled with blood. So we can't even look in. So this whole area, instead of seeing this area which is clear vitreous, the gel, it'd be red blood. That would be very severe diabetic retinopathy. And luckily, only 4 million people with diabetes have this type of blindness from diabetes. So it is preventable by seeing an ophthalmologist regularly, at least once a year if you have very early diabetes or newly diagnosed diabetes. But you may have to see your eye specialist, somebody like me, a retina specialist, more often, like twice a year, 3 times a year. And sometimes if they're under treatment, more often. There's new treatment, monoclonal antibodies, anti-VEGF treatment we inject into the eye, and it has changed the course of blindness for diabetes, and we also have laser, an old therapy, but it's still used, very useful, and again can prevent blindness in diabetics. And most importantly is diet, exercise, and adhering to the medication schedule that your endocrinologist or primary care doctor has given you as a diabetic. So don't forget your pills, don't forget to exercise. You eat every day, try to exercise every day. Some people load up their exercise to 3 times a week. That's better than nothing. But I always tell my patients, you eat a day, every day, so you might as well exercise every day. And the old wives' tale, walking after every meal, that's good. It'll help you. It'll get the insulin out of your pancreas, so walk after the meal. If you walk before the meal, you'll get more hungry, eat more. So that's not so good. It's better to walk after the meal, walk it off.
Dr. Wu, do you care to explain to us what age-related macular degeneration is and what glaucoma is?
Well, age-related macular degeneration is the leading cause of blindness in America after age 55. It happens worldwide. It used to be thought that the Asians did not get it, but that's not true. They still get it. They get a slightly different version, but they have 2 different versions of it in Asia besides just regular age-related macular degeneration. But for us in America, age-related macular degeneration means that as we have more age, more aging, more birthdays, we're prone to get it. What happens, what are the risk factors, is lifelong exposure to sunlight, UV light. And so after 1985, 87, we now realize sunglasses are very important, and UV protection of the sunglasses, front and back of the sunglasses, is very important. Smoking, high cholesterol, and there are genetic factors. They can find blood tests for it. However, that this has not been reimbursed by insurance because largely it's been a study tool. We cannot predict with certainty who gets it, but we do know the gene and that certain genetic markers within families makes you more prone. So therefore, if your mother and father have age-related macular degeneration, or everybody in your family or your sisters and brothers have it, start seeing an eye specialist, an IMD, a retina specialist, starting at age 55, even if you have no symptoms. And if you start having visual symptoms, see them before, because there has been treatment that can really prevent its spread from dry age-related macular degeneration to wet age-related macular degeneration. Dry is when it's the non-bleeding type. 90% of people have that. And wet is when it bleeds. And for the wet type, we have injections that have really wiped off blindness for age-related macular degeneration since 2006. There's several companies that have been very important in that change, that journey towards vision for these people with age-related macular degeneration. Genentech with Lucentis, Eylea, which is made by other companies, and Avastin, also made by Genentech. So this is very important for the home audience to know that you no longer have to have the same vision journey as your parents who lost their vision. So it's important to check in. And glaucoma. Glaucoma is what happens if you look at the eye again, right around the brown part of the eye or the blue part of your eye. Behind it is called the ciliary body. That area makes aqueous, a fluid that keeps your eye formed every 20 minutes. And then if you look at your eye, and right round here would be a little black dot. That would be a plumbing mechanism called the trabecular meshwork. That's the drainage. So every 20 minutes you make fluid and it's being drained by your eye and circulates. So it's like water, turning on water in your kitchen sink, and if the pipes are working, it would drain and nothing happens. Your kitchen sink is working. But imagine the pipe is stopped up, you would have overflow. But since the eye is a closed system, you cannot have overflow. So instead, this eye would be a closed system, and the water or the aqueous would build up, and you would get damage here to the optic nerve. So a lot of people, we have approximately 4 million people with glaucoma in America. Some people are still not discovered. They do not go see an eye specialist. In fact, only 3 or 2.5 people see an IMD or an optometrist once a year. People take their cars in more often than they see an IMD or an eye optometrist. So people do not take care of their eyes until they've lost vision.
So, Dr. Wu, do you suggest anything to patients, the general population, on how often they should get their eye? I know you said 1 year, but is there anyone in particular, any particular group that's at higher risk that should come more frequently?
If people have high blood pressure, diabetes, or they have autoimmune disease in their family, if everybody in their family had rheumatoid arthritis, they have a history of severe allergy called atopy, they should see their IMD sooner than age 40. It's recommended now that people have their first exam for glaucoma at least by age 40. So you can take children in to see us as early as 2 years old to check their visual system. And obviously, if the pediatrician has identified that your child the eyes are not straight or they're crossed or there's no red reflex. When you take a picture of a camera, sometimes you see the red reflex, the bright red. If your child is missing that, it's called a white reflex or leukocoria, and that could mean something very bad. So children can be seen as newborns. We see them in the nursery when we're called by the pediatricians or the neonatologists. So we see them all ages. We see them from 0 to age 106, however long we're all living these days.
Do you see any other huge causes of blindness in your day-to-day practice?
I'm a retina specialist, so I see 2 out of the 3 leading causes of blindness. I see diabetic retinopathy and age-related macular degeneration. And number 3 in the world is uveitis. That's an inflammation of your eye where your eye attacks itself, sees itself as foreign. And that can happen from trauma to the eye, if there's penetrating trauma, or history of autoimmune diseases such as sarcoidosis, rheumatoid arthritis, any of the collagen vascular diseases, systemic lupus erythematosus, psoriasis with arthritis. It can run in families. Raynaud's syndrome, Sjogren's, where you have a dry mouth syndrome. All of that can be related to uveitis. They can present with, first with the eyes feeling pain at sunlight, little floaters, pain moving your eye from right to left, sometimes a redness in the eye with the sensation of the sunlight being painful. So pain moving the eye, sunlight being painful, or any sort of light being painful, floaters, a red eye that will not go away, an achy red eye, or an eye that just aches all day, moving your eye just normally to read is painful. Those symptoms, you should definitely see an ophthalmologist.
So, Dr. Wu, I wanted to ask you, I've seen a lot of patients in the clinic who start to lose their vision, and it's very difficult for a lot of them. How do you suggest someone cope with this? And I know it's incredibly difficult to reverse. Is there any suggestions you have for them?
Well, in a general medical clinic, many people probably are losing their vision from diabetes and high blood pressure. Is that what you found?
Yes.
So for those conditions, number 1, send them to an ophthalmologist because it may be reversible even then. And number 2, there are websites. There's, if you type in blindness in Google, there are major websites that will deal with you, tell the patient, have support groups, but tell the patient their a Bill of Rights, in essence, or what they can get from the community in terms of social services, what they're allowed as taxpayers. But really, if they are in a hospital setting, and that if they have any vision at all, send them to an ophthalmologist, because there are amazing treatments that have come in the last decade that have reversed decades of blindness, at least get them from a state where they only see the big E, which is 2400, to a better level where they can navigate around their house and not necessarily have a white cane. Now, the white cane has been improved when people were totally blind, no vision at all. That concept has improved because the white cane now comes with an ultrasound. So the white cane, besides just telling people that you are blind and you're visually handicapped and to give you more space to negotiate the sidewalk or whatever, the white cane comes with an ultrasound device that will beep, 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 or talk to you and say you're 7 feet from such objects. And this was created in Europe, and this is available today. You can go and find this. So it's a white cane, a talking white cane. The other things for people with blindness is we have something called Argus 2 retinal implant made by University of California, San Diego. It's an implant where it surgically takes about 4 hours. You implant it underneath the retina as a surgery. There's another electrode placed right by your ear, and you're wirelessly connected to this electrode, and we found that people who were previously had no vision, where the room was black, they can at least see to walk around. They did videotapes of them before and after. It is covered by Medicare. You need to see an ophthalmologist to see if you are eligible for this. It's approximately $100,000, but it is approved by the FDA in America, and Medicare will cover it. It's for specific patients. We've had more patients in Europe with this device than in America. I think people don't know, and that they're not aware that things can help them. Other things about blindness, there are glasses that magnify for you, that you can hold it as a magnifier. You can buy special glasses where they'll put a magnifier built in, and I believe certain states will allow you to drive it with them. And there's one other thing in terms of blindness, is that there's now an implantable implant lens. So here, they would put the little implant in here. This is for severe age-related macular degeneration, and certain centers are doing it, where they actually put a little telescope in here. So this is better than nothing, not having any vision. So people do not have to feel that. And lastly, in the last 5 years, they feel that it used to be the eye would be connected to the brain, to the occipital lobe, the back of the head, and that they used to think that area was the only area that led to vision. So if you had a stroke in the occipital lobe, you would have no vision and it was all over. But they now think that the areas next to it, the striate cortex, play a role, and there's connections, neural connections, so that people have vision. They call that blind sight, so that those connections can exist and that people get some vision back. And there have been some interesting studies within the last 2 to 3 years that within the retina, which has 10 layers, and they've studied all these people who are thought to be blind, only seeing barely a little bit of light. They found that there are photoreceptor cells, which are rods and cones, which we've known that they've always existed. There are 127 million of those, but there are photoreceptor ganglion cells, which used to be thought to play a role in glaucoma. But these cells react to 480 nanometers of light, which is different from the blue light, only 10 nanometers away from blue light from the computer. So shining this light in these people, they could see. They did experiments. So this is very exciting for the field of glaucoma and for the field of how the plasticity of the brain and the plasticity of photoreceptors to enable vision. So this is all exciting, very new research, and people should type in ARVO, the Association for Research and Vision in Ophthalmology, and see all the latest news about it, arvo.org.
Going back to glaucoma, I've heard that certain ethnic groups are particularly, I guess, prone to like low tension glaucoma. It's like where you don't have to have high blood pressure or high eye pressure, and you can still get glaucoma.
So, that's a good question. So, what happens with glaucoma? It used to be three ways to diagnose glaucoma. The pressure is what's the eye pressure inside the eye, the visual field, which is function, can they see peripherally, and looking at the optic nerve. And since that time, they found that people would have normal tension or low tension, yet still have visual field loss. So their peripheral vision is still bad, but their pressure is normal. And that and how do we treat that? And then there's also something called ocular hypertension study, where people had high pressure, but the visual field was normal. So for these groups of low tension glaucoma, normal tension glaucoma, some Asians have it where they're extremely nearsighted. So the eye is not round like this, but instead oval. So, and being oval, they think that this collagen material that makes up the sclera and the optic nerve casing is abnormal. And being abnormal, that the whatever pressure is exerted is too much. And in addition, the actual measuring device is not calibrated. So that's one thing. So that's why it's low tension glaucoma. And this subgroup of people, like if you're very myopic, your optic nerve looks different. It doesn't look like everybody else's optic nerve. It looks excavated, caved out, looks whiter. So it's very hard to read for the eye MD to read, the ophthalmologist and the optometrist, but we now have better instrumentation in dealing with that. But still, it's a gray area because you can have Asian children with an optic nerve that's very abnormal and everything else is normal, but their optic nerve looks like a severely glaucomatous eye. So those people need to be followed because we don't know if they're going to stay looking abnormal but have no glaucoma, or they're going to become a glaucoma patient at some time. They may come, and that's something that's ongoing in Japan and China. China also has a different type of glaucoma. They get angle closure glaucoma. So it's thought that in rural China, where the eye is slightly smaller than usual, that all these structures in front are crowded, and that there a tendency, so as they get more birthdays and the lens gets bigger, this is already crowded, this pushes more, and the angle is closed. The angle houses the plumbing mechanism, the trabecular meshwork, so they get angle closure glaucoma. There was a large population study in China just a few years ago. And for those people who had cardiac procedures, they also get low tension glaucoma because when they cross clamp the aorta and there's less blood flow through the internal carotid, there's a period where there's relative low flow to the optic nerve and there's damage. And they have normal pressures, but they lost visual field. And we again don't know truly how to treat them, except that we treat them as glaucoma because we have no other way to treat just the optic nerve alone. Although things are coming, medications are coming in the development pipeline within the next 2 to 5 years that will change that. And now glaucoma medication companies are coming up with new ways to insert implants or other ways to implant medications. One of the problems with glaucoma, because it's still a leading cause of blindness, is that there's 85 to 65% non-compliance. But to make everybody else feel good, 85% of the American public do not take their high blood pressure pills either. So it's not that only eye patients are not compliant. 85% of the world do not take their medications. So especially for glaucoma patients, this is very difficult because if you don't take your medications, it's painless progressive visual loss, and that can be very hard. There was a New York Times article this month, February 2017, where Jane Brody was the author, and she talked about a journalist who lost vision, a male journalist. He did travel journalism, and he also was a novelist. And he felt extremely sad because he had to depend on people. He had to ask strangers for help. He could no longer see the sunsets that he wrote about. He could still hear the ocean. hear a waterfall, but he really couldn't see. So that is what we in ophthalmology want to fight for. We want to fight against that, and we want people in the home audience to know that this does not have to be you. You have to go see an ophthalmologist as soon as you think something is happening to your vision. Don't wait. Don't think it's going to get better on its own. Don't wait for your eyeball to fall on the floor before you visit one of us, because we're all accessible. And also, if you visit the American Academy of Ophthalmology website, there is a list of ophthalmologists all over America who will see anyone with a vision problem for free if you qualify. And all of us in the American Academy of Ophthalmology, I am a member too, we will see anybody with a vision problem, because we feel very important that we can all fight blindness together. And it's awareness, we want to tell people that's very important, that we can help people. And for your patients in the hospital, were they given ophthalmology consults?
As frequently as possible. But it was still up to the patients to go and visit the ophthalmologist themselves.
And so sometimes people don't like going to see us.
Right.
It's a problem.
It's a very touchy
Yeah.
subject. And people don't like being prodded in the eye because they're scared.
Well, they're afraid, but we're actually really painless. We don't do puff tonography. We just we numb the eye. Everything is painless. I've never seen any. We're much better than a dentist's office. I mean, maybe that's not saying enough, but we're totally painless. And with children, is no touch technique. We don't touch them. We have funny animals. We have videotapes. Instead of the big E, they have moving animals, cartoons. I mean, they could have that eye chart. That would be fun. We talk about animals. But the take-home message for the home audience is that blindness is preventable. We want to see everyone who has vision problems, and there are hotlines to call, and you can type in on Google about blindness prevention, leading causes of blindness in America. The 3 leading causes in America are glaucoma, diabetes, and age-related macular degeneration. We didn't really talk about cataracts because in a developed country like America, it has been taken care of with 98% success rate. So thank you very much for joining us. And if you like this show, donate to KSAR TV, KSAR TV, Saratoga, California. And thank you for joining us.